So up next, Kendrick. He'll be speaking on use of artificial intelligence and enhancing triage of patients presenting with chronic visual impairment in Hong Kong.
Thank you, Dr. Dave and Professor Chaudhry for chairing the session. I'd like to thank my mentor, Professor Dasana Yake, who was here just now, but for her very helpful comments. So my project is focused on patient care enhancement, and we're using artificial intelligence, particularly in simple investigations, to be able to triage patients better in our public healthcare system. So this project was very kindly supported by the Health Bureau of the Hong Kong SAR, but we don't have any financial interest to declare. So we have an aging population and we have a growing incidence of cataracts, and this is worldwide. One of the major issues that we have in Hong Kong is an overloaded public healthcare system. We have about 350 eye doctors in Hong Kong. That's for 7.8 million patients. But if you think about it, that sounds quite good. But if you really look into it, about 2/3 of our doctors are in private practice, and more of these doctors are going to private practice every year. So I really hope they don't listen to Dr. Ash's presentation, because that really gives them a very good idea. But what this means is that 90% of our specialist ophthalmic service is provided by the public hospital, but we only have 1/3 of the specialists manning it. So it's a really overloaded system. And the reason why it's overloaded is because it's free of charge. So patients don't have to pay for surgery. They don't have to pay for their lenses if they go to the public sector. And so they know it's high quality, they know it's free, then why better than to choose it? So how do we limit access, or how do we manage resources? We do it by waiting time. And the problem is that the waiting time, especially after COVID, has gone to the sky. It's basically 2 years, 3 years for waiting time to be seen, and then another 2 to 3 years to actually have the cataract surgery. So you're talking about 6 years after not being able to see. So that has gotten so bad that our chief executive of Hong Kong has actually forced us to increase 20% throughput of cataract surgeries. But how are we going to do this? Now, if you just increase the number of surgeries, you might not actually have that many patients who are eligible for the surgery. And that's because they have to be seen, they have to be assessed, they have to undergo pre-op assessment. And so if you don't increase your capacity to be able to see these patients, you're going to be left with an increased capacity without any patients to do surgery. And so the major bottleneck for our triage and referral is really getting the patients into the system. In order to be seen by our eye doctors in the public healthcare system, you need a referral from a medical practitioner. Now, these are assorted to P1, P2, P3, so urgent, early, and routine. Now, P1 is basically somebody with sight-threatening conditions, for example, a retinal detachment. P2, you're talking about patients who may have something in the pipeline, but not immediately. And P3 are those patients who can wait. Now, this system helps to prevent any irreversible blindness, but it doesn't help in terms of cataract workload, because cataract is reversible, and so these patients can wait. Because if you wait 2 or 3 years, or if you do it now, you can still do the surgery and restore vision. And the problem is that if you look at a referral letter, there's an inconsistency in the amount of information that you're getting to do a good triage. So it can be as simple as this, saying the patient has blurring of vision, there's no time period, no severity, no visual acuity, and you have nothing else to guide it on, and just give them a routine referral. So what we want to do is to enhance this triage system to see if we can take out those patients with cataracts who can benefit from earlier surgery. Because if you're waiting for 4 years, 6 years, they will have lack of work. They will also have difficulty in mobilization. They have falls, injuries, and hospitalizations. So the benefit of machine learning is the idea that you can train an algorithm to be able to predict things without really teaching them. So the idea is you show them the photo and you give them the end result, and they start to make the connections. So they can make better connections than us. And if you look at a fundus photo, this is what we've discovered over time, is that we have family physicians all across Hong Kong. So these are in general outpatient clinics. They all have fundus cameras. So if you're looking at a fundus camera, you're looking at the back of the eye, but oftentimes what you see is blurry vision. And in actual fact, this gives you an idea about how the cataracts are. So having this machine available, you can take the photo without much skill. You can use that to interpret how dense the cataracts are. So the part A is to train and validate the model. Part B is to actually compare it to current practice. So this is the system that we used and the algorithm. So it's basically, we're dividing it into training, validation models. And so we used a data set of about 16,937 fundus images. This was from another project I was involved in for 5 years, where we collected that data from those patients. And so we split it up into different validation, training, and testing algorithms. And we also had the output to be either normal, early cataract, or visually significant cataract. And we also used a visual acuity to define that. So normal, no cataracts. Early cataracts means that there is cataracts, but the visual acuity is still better, 20/40 or better. And visually significant cataracts are those that are worse than 20/40. So these are the primary and secondary outcome measures. And if we actually look at the internal validation model, you can see that it performs very well. You have an overall accuracy of about 90%. AUC is actually quite good across the range. And if you look at the external validation, where we took a different set, so these are 600 patients that we took from our OPD, you can see also very good results, albeit a slightly lower AUC compared to internal validation. So we put this into clinical use, and what we saw was that the machine was starting to recognize that the area around the disc and the macula was very important in the heat map. And so if it could identify the disc and the macula very clearly, then the cataract was less, and so forth. So if it was very blurred, then it determined a much more likelihood of cataract. And so the real world usage, we plugged it into about 638 patients that we recruited prospectively. And what we found was that if you went for routine referrals, all of these patients would be seen within maybe 2 or 3 years. But actually about 36% of these patients already had clinically significant cataracts, and actually about 4% of these patients saw worse than 20/800, which meant that yes, these patients can wait because they're not going to go permanently blind, but if they're waiting, they're really not functioning in society. So this algorithm really does help in pulling out these patients that our triage system wouldn't be able to pick up. And so the positive effects is that you can use a tool that is widely available and just use an algorithm to be able to help and further triage. So basically you have a different line to be able to increase your cataract output. But the limitations is single condition focus, and it only works in the context of chronic visual loss and not acute visual loss. And it relies on a greater capacity of cataract surgery. So if you have more patients going to the system, you have to have the greater capacity to do surgery. So in conclusions, I think machine learning will really help us in triage. And so it really does help to identify the patients who will benefit from early cataract surgery, and we can incorporate that into a primary care system with the use of this as an aid. So with that, I also do want to mention 2026 APAO. This year has been fantastic. We have a lot of work, so I'll be co-chairing the next session. I'll be looking forward to inviting you all to 2026 APAO. What better way than to go to Hong Kong once, but to go to Hong Kong twice in 1 year. And so we will also have the Asia Cornea Society, which will also be part of in the organizing committee, and we also hope to welcome you there. So one in the beginning of the year and one at the end of the year. Thank you, everyone.
Any quick comments or questions for Kendrick?